everybody. Recording live from somewhere. This is Zach Couples with episode number 101 of the Movement Debrief. And tonight, folks, we're going back to the basics. We're going to talk about anteversion and retroversion of the femur. Is that a big deal? Does it influence movement capabilities? What you gonna do about it? Stay tuned. We're going to talk about squat stance. How wide, how narrow, what should your squat stance be like? I'll give you the answer. And last but not least, we're going to talk about tissue tolerance. Why is that important? Is it just relegated to muscles? How do you educate tissue tolerance about other things? And yes, man, I am cold as all hell because these are questions. These are ice cold questions that have been asked by the people. They'll be answered for the people by this people right here. Fam recognize fam. Without further ado, let's debrief, shall we? The first question comes from my dude, Tim. Here's what Tim asks me. Debrief fodder. Differentiating between foot external rotation, toeing out, caused by legitimate hip retrotorsion or version, and foot external rotation secondary to anterior rotation of the innominate, corresponding with acetabular orientation. Is it bony structure or a changeable pattern? Is keeping a foot straight a key performance indicator of archetypical human movement? Tim, this is an awesome question. I'm really glad you asked this because it really forced me to kind of deep dive into the research on anteversion and retroversion, something I've been meaning to do for a hot minute. So what's Tim talking about here? What is anteversion and retroversion? So anteversion and retroversion has to do, if I can, let me take the femur here. So I got myself a femur. Anteversion is normal, first off. It has to do with the angle of the femoral neck in relation to the bottom of the femur. So if you're looking at a hip top down, this would be the front part of the hip, this would be the back. The femur is more oriented forward, or there's a twist of the femur forward towards the front of the body that in normal populations, whatever that means, ranges from, I pulled up some research here, and I'll link this research in the show notes on zachcouples.com. I believe what they say is normal is 16 degrees. It's going to be much larger in kids, and then in a perfect world, it would get smaller to around that 16-degree mark in adults. And that's actually stops at around the age of 16. But really, the values have kind of been all over. I've seen normal be considered 10 to 25 degrees in one study. But I think 16 degrees is pretty solid. Was good, TJ. So that's normal anteversion. We'll say 15, 16 degrees. Anything beyond that would be increases in anteversion of the femur. Anything less than 15, or like in this study that I like by Lurch et al., anything less than 10 is retroversion, retro backwards. So that would be, instead of having the head of the femoral neck way far ahead of the bottom of the femur, it would be closer to 0 or behind in some cases. That's anteversion and retroversion. In theory, what they would say is if someone is more of an in-toer, toes pointing inward, or it's IR, that would be an individual who presents with more of an anteverted based hip. These would likely also be W-sitters in their childhood. They would, in theory, have way more internal rotation than they would external rotation. Retroversion, flip all that. This would be what Tim's talking about. That's someone who's got more of an out toe. That would be way more external rotation. They'd be sitting more crisscross applesauce, and it would have a loss of internal rotation, in theory. The question is does this stand up to what we're seeing movement-wise? Well, first and foremost, anteversion and retroversion are a legitimate thing. This does exist. The cons, though, is there's nothing really that we can assess as clinicians and movement professionals to see if someone really is anteverted and retroverted. Let's go into some of the problems of measuring anteversion and retroversion. And the studies I'm going to be referencing this from, which will be linked, is this one. I really like this one. It's like a review: determination and significance of femoral neck anteversion, and then prevalence of femoral and acetabular version abnormalities in patients with symptomatic hip disease. That's what I'm pulling from. All right. So, first question is, can we, as movement professionals, measure if someone is anteverted and retroverted? And it turns out, not so much. The quintessential test that people were performing back in the day is the Craig's test, which basically what you do for that is you would lie someone prone, you would bend the knee up, you'd use the greater trochanter as your marker, and you would move the femur until the trochanter was most prominent laterally, and the amount of rotation that you would have would signify the degree of anteversion or retroversion. Turns out, according to the 2004 paper, the one that I am linked, Determination and Significance of Femoral Neck Anteversion, not a great test. It's gotten mixed reviews. There's only been 2 studies done on it. One showed it was the cat's pajamas. The other was kind of questionable about it. So probably not a good test. Can't necessarily signify the exact angle of anteversion or retroversion when compared to the gold standard, which is CT. Now, hip internal-external rotation. So it's commonly thought that people who have more retroversion have tons of ER and limited IR, and vice versa for those with anteversion. What if I told you, though? There was a study done that was mentioned in one of the studies I'll link to. This is by Gelberman et al., and I'll link that in the show notes as well. It was an older study done in the 80s, but they took kids who were in-toers, i.e. lots of anteversion. And they did research to show that these kids had anteverted hips, so they did imaging to confirm that there was femoral anteversion, and they compared prone hip internal-external rotation measurements to seated or hip-flexed hip internal-external rotation measurements, which obviously changes the mechanics a bit. Here's the interesting thing about this study. Many of the kids who had severe anteversion presented with large amounts of IR in relation to ER in both the prone position and the position with the hip flexed. But, there was a subset of those kids. Generally, they had less anteversion, but it was still enough that it would be clinically meaningful, who had, in the prone position, large amounts of hip IR in relation to ER, but once you flex the hip, that relationship reversed. These kids then had large amounts of external rotation of the hip compared to internal rotation, so much that there was more ER than IR. Point being, by this study, is if there is a subset of population who has anteverted hips and you can't, and the rotational measures don't match, then it signifies that measuring rotation is an unreliable marker for determining if someone has anteversion or retroversion, which is important from my standpoint as a clinician, because we can't necessarily make the leap that because someone presents with a specific hip rotation, that correlates with anatomical changes. And in fact, in this study, and this is about the Sobolka, the determination of significance of femoral neck anteversion, he argues that in some instances, you might be able to change the degree of anteversion and retroversion in some cases. So, in animal studies, let me preface with this, but don't worry, I'm going to get to the human stuff. In animal studies, keeping the hip either in external or internal rotation can drive relative retroversion or anteversion, respectively, as can hip rotator resection. So forces undergone on the femur can change the angle of retroversion versus anteversion. He also cites some research showing that sleep posture could also potentially impact relative anteversion and retroversion. Okay, so there's ways that these bony adaptations could potentially change, although he did not list the degree that it could change. Just like you can have bone growth with resistance training, you could probably have bony adaptation changes by altering and manipulating the forces undergone. But here's the important piece that I would say from this study. And I'm going to read this. It's a quote. So, because of the difference between medial and lateral rotation of the hips, internal and external, are related to the femoral neck angle, which would be anteversion or retroversion, I believe that physical therapy interventions aimed at restoring symmetry in hip motion is a reasonable approach to manage hip problems. And also, to follow back on that, there have been no studies done showing that restoring hip rotation in people who may have anteversion and retroversion has any negative or positive implications. They don't know if this can change or not. So a lot of people demonize that if someone has anteverted and retroverted hips, which we can't really assess, that you shouldn't perform any types of interventions to change the rotational components. That's also a misnomer because there's no research showing that is good or bad. But of course my bias is kicking in, I would have to agree with Cebulka because if we can do some things to improve someone's movement options in general, we should probably do that. There's a lot of cases where you can have someone who has anatomical presentations that don't necessarily manifest as movement limitations. A prime example of that is people with hip osteoarthritis of any joint. I've worked with quite a few people who have had imaging-confirmed knee osteoarthritis who have full knee range motion. The anatomy does not always match the movement presentations or the static posture presentations. So we can't always say that someone's foot toeing out is because of anteversion and retroversion. My personal opinion is I think you can impact rotational measures way more in more people than in those who you can. And if you're not getting some substantial changes in hip rotation, then maybe there is a structural component that's not necessarily anteversion or retroversion, but changes within the joint surface. So anteversion, retroversion, probably not as likely of an impacting factor, I think, on foot position. That being said, that's only one component that could potentially contribute to someone being more of a toe out or toe in type individual. There's several other things that could be going on. Same study by Cebulka. Excessive in-toeing and out-toeing has been shown to be related to many different compensatory problems of the lower extremities. That includes tibial torsion, torsion of the tibia, a rotational issue within the bony structure of the tibia. Genu valgum and verum. Do you have knees that collapse in, knees that collapse out with, that's influenced by femoral rotation. Pes planus and pes equinus. If your foot is flat or if it's caved, that's going to influence the foot orientation you have. And metatarsus varus, so alterations in foot position. Lots of orthopedic issues could contribute to the orientation of the foot. We can't always assume that there's an anatomical component at play. Point being. So with all that being said, there's lots of influences that could make someone's foot position be that way. What can you do about it? To me, my bias, of course, is I think that there are several potential factors at play. I think your most prudent aspect or prudent thing you can do is restore that individual's movement options and see what shakes out. Their foot might not be straight, but if they have all of their motion available and they can demonstrate good quality movement in whatever task it is that they want to do, then it's probably a worthwhile thing to pursue. We have to consider if someone has more IR or ER of the hip, the axial component. If someone is in more of an anterior orientation at the pelvis, the femurs are going to have a tendency to fall more into IR. If they can't reverse that and go the opposite direction, that's going to impact the amount of rotation that's available at this joint. That could potentially impact whether they're toeing out or toeing in, depending on all the other factors that I've listed. And you could move that down the line, right? I might fix the femoral rotation component, but maybe I have someone who has a foot issue or there's still some tibial rotation issues at play. You can just put them in the other direction and restore the options that way. And while I can't necessarily give specific things based on the case-by-case it would have to be a case-by-case basis, but I mean, consume all the information that myself and others are talking about. And that will probably be a very useful thing for your people. Now, Tim is also asking, is straight foot the KPI that we want to achieve? Now, in the weight room or the training room or the things that us movement people like to be in, why are we putting people with the foot straight in a lot of activities? From my perspective, my goal is to maximize movement options throughout the body. Most people have movement limitations within the ventral cavity. If I am fixing the femoral component in one direction versus the other, so I'm fixing it straight, and let's say I go to do something like a split squat, where I don't have any rotational action happening at the knee. In order for me to achieve depth, if I'm not using a femoral strategy to get myself into position, so a prime example of that would be ERing the femur so someone could achieve depth, I have to get those dynamics elsewhere. The place I'm going to get it is at the ventral cavity. In this case, the pelvis has to be able to, if I'm doing a split squat and I'm trying to stay straight up and down, the pelvis has to be able to counter-nutate to a degree to allow for that straight up and down position of the pelvis. That's why with many of the activities that I do and others do, we're keeping the feet straight, and that includes squatting. Stay tuned, we'll talk more about that in a hot minute. Now that being said, now I know Tim is a runner. He's a friend of mine, and I know that's really what he's probably getting to. So don't worry, Tim, I got you, because do we then transfer that to terminal activities, which would be sport, or in the case of Tim, running? Because if you look at a lot of the elite runners, many of them have foot external rotation, or they're toeing out, and they'll have crazy amounts of pronation or supination or somewhere along that continuum. So then the question is do we need to be coaching people in their terminal exercises to keep the foot straight? And the answer is, I don't know. And the reason why I'm saying I don't know is because we would have to look at if there are technical issues within each sport that make people perform better or faster. If only there was a research article that would talk about that in the case of running. Oh, wow, here it is. Here's a great study. Running technique is an important component of running economy and performance. This was done in 2018 by Folland et al. I'll link it in the show notes. I strongly suggest you read it. But there are correlations, about 50% correlations, but here's what they said. If we're talking about running economy, which is can you run as fast as you possibly can while having minimal cost to your body, there are some variables that can account for 39% of running economy and 31% of your performance can be explained by your technique according to this 2018 study, which I thought was pretty profound. What are those things? Well, I'm glad you asked. Four key variables when we're talking about running economy. Vertical pelvis oscillation. The more up and down movement, the more jumpy movement you have at your pelvis, the less economical you're going to be, the more it's going to cost you to run. You're going to be slow. That's one. Number two, minimum pelvis horizontal oscillation. So if you are not moving your pelvis forward and backwards because you are overstriding, that's going to slow you down. If you take too large of strides, you have this huge concentric action that has to happen from a maximal eccentric strategy. That's going to fatigue the muscles quickly because you have to utilize more substrates to generate this very strong contraction to finish the stride. So we want more pelvis horizontal movement. Reduce transverse plane pelvic rotation. I'm a runner. It's more of a linear action. If I'm rotating all over the place in my pelvis, I am wasting energy because I'm accounting for movement that has to occur in more than the directions I need, which is straightforward. And other things. More upright torso. That was shown to have better running performance. Shorter ground contact time. and less time in between each stride, so shorter strides. All of those factors have been shown to improve performance and running economy. Another thing that stood out from this is greater knee extension during ground contact and swing. So the quicker you can move your feet and get your leg underneath you and get close to full knee extension, the faster you're going to be, the more running economy you're going to have, the less cost it is to run. So then the question is your strategy that you are utilizing to run, is your running form, accounting for these variables? If you can take care of these variables, minimize your vertical pelvic oscillations, you're getting good horizontal movement of the pelvis, you're staying more upright, you have small ground contact time, little time between steps, and you can hit knee extension, but your foot's turned out, then you're probably doing okay. But if you are taking super long strides, and that's the reason why your foot is turning out, that's probably negatively impacting your running economy and your performance. And is it because that's just how you're built? Seems to me that the research doesn't support that. Your best bet is to maximize your movement options at a baseline level and be able to demonstrate those options all the way up to your terminal activity, which in the case of Tim is running. That's what I would say you have to do. And that could be doing some things or changing your running technique in a manner that allows you to have some of these qualities that are needed for distance runners in order to run fast. One of the cues that I often will do for a lot of these individuals is making sure that we're getting more front side mechanics, or the arms are going a bit more out in front of you. I had a good conversation with a friend of mine, well, friend/enemy, we'll call him a friend of me, and he's going to love that I called him a friend of me because I'll throw shade at him anytime. Hunter Charneski, which, you know, as much as I hate this man, you should follow him because he's a really smart guy when it comes to sprinting. But I talked to Hunter about this because I've had some people ask this. Hunter is a disciple of Derek Hansen, who I'll also link in the show notes. I said, hey, man, like, you know, obviously with fast running, you want the hand at about eye height. And but what about someone with distance running? And if he's doing tempo work, a lot of times they will go to nipple height. So I think nipple height with the hand, or even slightly below that, is probably a worthwhile thing to pursue from mechanics if you are racing and you're doing distance running. Because a lot of times if you cue the front side mechanics, that will reduce the braking action, which is shown to be a negative thing when we're talking about running economy and performance. And that could be just one simple cue that you could incorporate within your running right now. And that could potentially have some very positive things occur with your running technique. So to summarize, this great question by Tim. Anteversion, retroversion, it exists. We can't really measure it. The gold standard is CT scan, but does it matter? I don't think it does as much as we think. I think what's more impactful is the proximal influences of your hip rotation when we're talking about your foot orientation. There are a lot of other factors that could cause someone to toe out or toe in. You should probably address the movement options first and foremost. That is a prudent thing. That is research recommended. And then if you can extend that to your terminal task to the best of your capabilities, figure out whatever it is you want to do. What is the gold standard or the best technical aspects that would allow you to perform well at your craft? Do those things, and you probably, more often than not, will be in business. Tim, great question. Now, if you're wondering, well, Zach, you talked about, okay, anteversion, retroversion probably doesn't matter as much. I don't really know how to maximize the movement options at the ventral cavity. How do I restore my hip motion? How do I transfer this kind of thing to the gym? Well, I got an answer for you, and the answer is Human Matrix. And we got a few left this year, and by a few I mean a couple. November 23rd and 24th is in New York City. That one is filling up quite a bit. We got a good group going there. Definitely check that one out. December 7th and 8th in Orlando, Florida. Early bird is ending next week, so you definitely want to sign up for that ASAP. January 25th and 26th in Scotts Valley, California. April 4th and 5th in 2020, Atlanta, Georgia, where the players play. And Round 2, February 8th and 9th, with myself, Pat Davidson, and Seth Oberst, where we destroy conventional wisdom in our industry, The Uprising. You definitely want to sign up for that. That's going to be in Boston, Massachusetts at Pure Performance. Holla for a dollar. The next question comes from Robert Beardsley. This is his anonymous name. Here's what Robert Beardsley asks me. My internet bros are always messing up the hips with wide stance squats and no internal rotation. Maybe an episode on finding the correct width to maximize range of motion and explain how impingement happens with a model. Is there such a thing as too narrow a stance? What's all this bullshit about opening up the hips? Retroversion, Anteversion. Robert, great question. So, squats. Squat, like, there's something, and I'm glad he asked this, and I waited to answer this question until now because I've been doing quite a bit of research on squatting, which I'll be discussing at the Uprising with Pat and Seth in February, because I think that most of us don't really squat. I think most of us actually hinge twice. So what we have to define is what is the difference between a hinge and a squat. For me, and this would also be supported to a degree by the research, a hinge would involve posterior displacement of the pelvis. So it's more horizontally oriented. There's more loading occurring with structures at the hip. A squat involves more vertical displacement of the pelvis. Pelvis should go up and down Charlie Brown. Now, we have to ask, let's pick apart some of Robert's questions bit by bit. Hip issues with wide stance squats. If I have a wide stance, let me compare a couple things. There's a good study, I've linked this a bazillion times, about the lumbosacral actions that occur with a back squat. As soon as a barbell is put on your back, your lumbar spine becomes kyphotic, which, if the lumbar spine is becoming kyphotic due to its relationship to the sacrum, there's relative sacral counternutation. This is going to shift the bottom of the pelvis, the outlet, more forward. I can't go super duper far forward because I only have about 15 degrees of extension available in the lumbosacral region. So my only option, if I continue the movement, is to drop straight up and down. In that case, a squat involves straight up and down movement. The lumbar spine is going to be more kyphotic. If I assume a wider stance, there is less motion that happens at the spine, i.e., there is less of that kyphosis occurring. If I wide stance this, I can't go straight up and down anymore. And partly that is because if I'm wide stance and I'm externally rotating, that's going to close the pelvic outlet early. I can't close it any further, so it's going to get smaller because as I descend down into the squat, the outlet should get smaller to a degree. So then my only option is to open the outlet. If the outlet opens, that's going to tip the pelvis more posteriorly. And that's why with powerlifters who assume a wide stance, instead of seeing that straight up and down motion, more often than not you see them shift the weight posteriorly. It's not just powerlifters. If you see anyone who gets some degree of posterior displacement on the squat, they're probably doing more of a hinge type pattern. When I have this posterior shift, according to some of the research on what's going on with a wide stance squat, those power lifters are actually picking up some rotation at the femurs. And the reason why is because they can't access that rotational component from the pelvis standpoint because they're hitting an end range position that doesn't allow for rotation to occur. So what will actually happen in this case is as I'm shifting the weight backwards, and I'm starting from an externally rotated position, this posterior shift is going to create some degree of internal rotation at the femurs. If I have nutation at the sacrum, or if I tip the pelvis forward, the femurs are going to fall into internal rotation. If I tip it posterior, it's more external rotation. So, Wide stance, starting in ER. I start to shift back. That's going to take up the IR. Some of the research on wide stance squats show that there's actually some internal rotation action that happens at the femur as well. In some individuals who maybe don't have much IR, but yet in a wide stance squats they have to IR in order to hit depth, that could potentially lead to some hip impingement because they essentially run out of room. That increases pressure on a certain aspect of the joint and potentially leads to that pinching sensation. That's basically what impingement is you've run out of room to mobilize the fluid within the joint capsule, and the tissues get compressed, problems ensue, you have some type of pain that happens. So basically, if you're doing a wider stance squat, you're stealing your degrees of freedom at the ventral cavity. Thus, you have to pick up that range of motion at the hip. If you've assessed any power lifters or people who are very strong and lift lots of weight, many of them have losses of hip internal rotation, which potentially, not in everyone, but potentially makes them more predisposed to getting impingement symptoms. So then the question is, well, if we're doing this, do I need to change my stance width? And I would say the answer depends on your goal. If you're a power lifter and your goal is to move the maximum amount of weight possible, and I don't have to necessarily achieve full depth like, say, an Olympic lifter, then potentially a wide stance squat is okay if you have the degrees of freedom available to perform that action and you can hit depth. If you can't hit depth, then that's a problem because then you're not going to win. So what you may have to do is you may have to do some activities that restore the rotation or even narrow your stance so you can get more vertical displacement of the pelvis, allowing you to hit depth. That could potentially, for some people, have a negative consequence in the amount of weight moved because it's a different strategy. Power lifters, most of their game is practicing hinge-like activities. The deadlift and the powerlifting squat, I would argue, is more of a hinge than it is a true squat. So training a strategy that is not that may take away from some of the performance capabilities of those people. Now, if your goal is just, look, I want to squat because squatting's cool, I'm not necessarily into powerlifting, I want gains mode, or maybe I want to use squats to improve movement options, then I think having a narrower squat that allows you to have that vertical displacement of the pelvis is a super worthwhile thing to pursue. Because that's a great way for me to restore some of the rotational actions. If I am in a situation where I'm in more of an anteriorly oriented or tilted position at the pelvis and I have range of motion loss, if I can get to the point where I can have a pelvis that goes in the opposite direction and I attempt to squat, which goes through pretty much most of the entire range of motion spectrum, that could potentially lead to some profound changes in movement capabilities at the hip. May make squatting with a wide stance more comfortable. It's also going to improve range of motion. Love you too, big dog. Range of motion within the axial skeleton, which is favorable because that could potentially give you more available activities that you could utilize to pursue your fitness gains. So for me, most of the people who I work with, I have them do narrow-based squatting. Of course, this is a population who is either in pain or they're doing multi-directional sports. These types of things are what they gravitate towards, not so much the powerlifting crowd. So I think it's important. If you can't do that, if you can't get the vertical displacement, a simple trick to do that is heel elevation. If you elevate your heels, and I've debriefed on this before, I'll link that in the show notes as well. But if you elevate your heels, some of the research that I've come across with squatting, that has shown to increase vertical displacement of the hips. It eliminates ankle dorsiflexion restrictions as you're shooting the knees forward, so you can allow you to drop more straight down as opposed to shooting back. And that would be, I think, for most people, a worthwhile thing to pursue. Maybe it's not your main lift for force production, but squatting with a narrower stance could be quite impactful from improving your movement capabilities, as well as loading some tissues that you don't normally load with a hinge. Like it or not, you're probably not getting the squat Oscar, I will answer that in a moment. Maybe you aren't getting as much quad as you think with the back squat if you're shifting your hips back, because there's more loading on the knees when you go straight up and down, which is beneficial if we're talking about getting squat gains. Hang on, Oscar asked a question. Knee sponsors. They stated no one. So Oscar is asking knee and spinal surgeons. A seminar stated that no one should be doing abductor work. What's your thoughts on that? I would want to know why that's the case. I don't know. Yeah, that's a great question. I think, like with a squat as an example, your abductors are most certainly going to be working because those externally rotate the hip. Anyways, so heel elevation will allow you to get more posterior or vertical displacement, as will narrowing your stance. But the question then would be, well, what's the best stance width for me? And I think this is important to ask because not all of us are built alike. Someone who's got narrow hips is going to have a much different squat stance than someone who has wider hips. And I would say, even though it's not a great answer, but the best way to determine your best squat stance is trial and error, with a caveat. If we know with a squat the goal is to get vertical displacement of the pelvis without shooting the hips back, what you want to do is find the stance that best allows that to happen. Wider stances aren't going to allow that to happen because it restricts the amount of motion available at the spine. And there has to be spinal motion that occurs for this in order to allow you to get that vertical displacement. For most individuals, I will cue them to go about their hip width, whatever that is. And that seems to be enough to allow that vertical displacement to occur. And of course, there's going to be up and down motions, or there's going to be adjustments that you're going to be able to make in order to maximize your squat depth. So to summarize Robert's question, wide stance is going to create more of a hinge action, not necessarily a squat. We want a squat to be more vertical displacement up and down. If you aren't getting that, you need to change something about your squat stance. Ideally, that would be likely elevating the heels to start and going with a narrow stance. Safest bet is to probably go about hip width, but what I would do is give yourself a side profile, film yourself with different squat stances, see how well you can maintain that vertical displacement without shooting the hips back, and you're probably going to be in a really good spot. Awesome question, Robert Beardsley. The last question comes from Lucy. And here's what Lucy has to say and ask. Whoop, hang on. Ruben, I will talk a bit more. I'm going to add Ruben's question to next debrief. He's talking about the deadlift, because I could go way more in depth into that than I probably would now. Let me just write that down before I forget. See, deadlift, stance, and ISA. Cool. I got you, Ruben. I'll get that next week, promise. All right, Lucy. Here's what Lucy asks. Zach, my man, what's good with you? And yes, Lucy actually said that. I do well explaining tissue tolerance for muscles, but if a client thinks that it's joint or nerve pain, I struggle. Help. Lucy, this is an awesome question, and let's see if we can sift through this. So what does Lucy mean by tissue tolerance? A good analogy I got from Tim Gabbett, tissue tolerance, who he's like the godfather of acute chronic workload, which you can get a calculator if you subscribe to ZachCouples.com. But Tim Gabbett gave the analogy of someone who's drinking. And let's say you drink, and let's say you're normally accustomed to having 3 beers a night. All right, I do not condone doing this, but let's just say that you have 3 beers a night. And one day you decide to go above that, and you go with 6 beers. And once you get to 6 beers, you start to get really drunk. You're sloppy, and problems ensue. Whereas with 3 beers, things were hunky-dory. That would be an example of where you went beyond what your tolerance is for alcohol, and you paid for it. If we extend that further, let's say you had those 6 beers and you're like, man, I am never going to drink again. That was a bad issue. You decided to quit alcohol cold turkey. You have 0 beers a day. It's 6 months down the line. You're partying with your boys or your girls, and they're like, hey, so-and-so, I want you to have some beers. And you're like, okay, cool. Well, I used to do pretty well with 3, so I think I'm going to have 3 beers, and we'll see how that goes. And here's what happens. You end up getting sloshed beyond belief. And you're puking, you're doing all that stuff, and you got the hangover the next day, and you're like, man, you're thinking to yourself, I used to be able to pound 3 beers like it was nothing. What the heck happened? Well, what happened was because you ceased drinking alcohol for an extended period of time, your tolerance to alcohol was lower. And then you went beyond what your current tolerance was, and you paid for it, i.e. you get a hangover, you get drunk, and all that stuff. We understand this when we're talking about something like drinking, but this concept of tolerance extends to just about everything. When you're performing an exercise, maybe it's playing tennis for 2 hours, and let's say you haven't played tennis in a long time. Your tissues are stressed in a specific manner that is akin to tennis, or that corresponds to tennis. The tissues may not be able to withstand that stress effectively without having some symptoms creep up. Maybe that's delayed onset muscle soreness. Maybe that's a little bit of knee pain. It could be a lot of different things. And the reason why this happens is because the tissues haven't been exposed to that stressor. And it was too much too soon, they couldn't adapt, and now you're getting some type of symptoms. But the hope would be that if you continued to play tennis for an extended period of time, your body would get used to that and you wouldn't have the normal symptoms that you would expect. Delayed onset muscle soreness is a very common thing for us to think about in the weight room. And I get this every time I do kettlebell swings. I do 50 swings in a session. My hamstrings are smoked and sore. I did swings the other day, and I'm still kind of sore from it. And that's because my tissues haven't been able to adapt effectively to something like a kettlebell swing. And symptoms occurred to let me know, hey, your tolerance isn't here. We need to chill this out. But then if I keep up doing the kettlebell swings, my tissues should be able to adapt in theory, and I should be able to perform that activity with minimal consequences. But Lucy has an issue if someone is thinking, because that's kind of an easy thing to explain to someone who maybe has a muscle-like pain. But what if someone thinks that, it's definitely my joint. I feel it in my joints this time. Or, I got some pins and needles down my hand, and it's kind of a nervy-based pain. And that's an issue. I don't want to follow the rules of tissue tolerance where I'm slowly exposing the tissues over time to a challenging stimulus. What do you do about that? Well, our muscles aren't the only thing that adapt to stressors. When we move, all of our tissues have to adapt to the stressors imparted. If I am a nerve, nerves, as I move, also move. They have to be able to stretch, slide, and glide. If you bend your elbow, you are pinching your median nerve. Nerves pinch. That's normal. In some individuals, if they do too much of an activity, that could potentially stress the nerve and make it more sensitive. But what you need to do is slowly expose yourself to whatever that movement is that offends the nerve in a slow and controlled manner. And these two will also adjust and adapt. I had this happen quite a bit to a lot of my NBA guys when I was in the league. We'd have people who had an ankle sprain who would have some peroneal nerve sensitivity along with that. We'd increase their loading after they recovered from this. They would get nerve sensitivity. And it wasn't a matter of stopping activity. It was about altering the amount of load that we exposed them to. And eventually this subsided, the nerves adapted, and we go on. The same thing is true with joints. Joints become healthy by compression within the joint surface, or not the joint surface, but within the joint capsule, and relaxation. So it could be a case, maybe you have someone who is running and they get joint pain in their hips, however you can differentiate that. And it may be the case that they did too much too soon. They have to maybe relax and recover a bit so the joints can adapt to the new forces that have been imparted on it, and then you would progress again. And the name of the game with all this is the whole body adapts as one. It's not you're isolating specific tissues and the other things aren't changing. Everything's changing whenever you're learning or you're doing a new task. And you simply have to, regardless of what pain or anything you're having, you have to just continue to progress slowly over time and in a prudent manner, making sure you don't go beyond someone's tissue capabilities. And while it's okay to occasionally have pain that could potentially be coming from various structures, and we don't want to necessarily push past that, but in order to be able to do more activities without pain, you have to expose yourself to those stressors with time and with an amount that doesn't go beyond the tolerance of the tissues. And it's this careful dance that we have to do. And even if the joints get stressed too much or the nerves get stressed too much, these tissues adapt like anything else. It's nothing to be afraid of. Just continue to progress intelligently and you should be in business. So, Lucy, thank you for a great question. I hope I answered that to the best of my capabilities. Thank you so much, though, for tuning in. I think it's a good stopping point for tonight because it's been a long one. Wow, we've probably been talking for a hot minute. So thank you all for tuning in. You've been a beautiful, sexy, outstanding audience. If you want to learn more, here's where you can find out about me. Go to zachcouples.com. Subscribe to my newsletter. You will get a free acute to chronic workload calculator. You will get, what else will you get? 5 hours of me talking. You'll get a free course on some basic movement mechanics. There's lots of stuff there. I also offer 3 services. Movement consultation. I can take you through some different moves. If you're not moving as well as you'd like to, you feel restricted, maybe you can't squat, I can help you with that by performing an assessment, taking you through some activities, and improving your movement capabilities. I can extend that also into your training where we can design a fitness program based on your movement needs and as well as fitness goals. So we can create an approach that will support both of those things. Or if you want to learn how to do that with your people, that's where my mentorship program comes in, where we will talk about how we can best implement this stuff into what you're currently doing. All of those services are available on zachcouples.com, so check me out when you check out the show notes. Once you've scoured zachcouples.com, you'll want to sign up for me on iTunes and Stitcher at the Zach Couples Show, because guess what, folks? There's 100 other debriefs, and you might not want to look at me for all of them. So definitely sign up for that and leave reviews so the fam can keep growing. Social media-wise, I'm on Facebook. That's /ZCouples. Twitter handle is @ZCouples. I'm on the Instagram, baby. Zach, Z-A-C, Couples, C-U-P-P-L-E-S. And also YouTube. Search Zach Couples. If you are there on Zach Couples on YouTube, you'll find a gang of exercises that I've been employing with my clientele. Usually you'll get most of the up-to-date stuff, and we'll go from there. Thank you all for tuning in. You've been amazing. Keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.